Over a couple of decades of experience in consulting firms specializing in emerging technologies, I feel fortunate to regularly engage with global leaders, stakeholders, innovators, and all those leaders who are driving positive change. Joining me today, I have great colleagues. Arvind is there, then we have Archana, and in the back end, I have Naveen, who will infusing energy into this event. So big applause for their dedication in making efforts to make this gathering a great one. Some facts about AI CoreSpot, which I wanted to bring it forward in this forum for all of you. It was founded over 3 years ago and is meant for a source of inspiration in the tech landscape, focusing on great emerging technologies such as AI, ML, robotics, IoT, and so on. Our webinars serve as a platform to share the latest advancements in these fields, providing fresh insights every month. And as we continue to gain momentum, we aim to be the leading AI-driven community worldwide so that we can foster collaboration and growth among like-minded individuals like you all. We are committed to curating industry-backed webinars and hybrid events, leveraging insights from industry leaders who, like today, we have great speakers, then subject matter experts, and all our trusted partners who deliver credible and valuable content. Additionally, our content is also crafted across various digital platforms, which includes podcasts, videos, blogs, monthly newsletters, which keeps all our audience informed and engaged. Now, bringing back the attention to today's webinar, which is connecting patients and providers, that is telehealth and RPM defining healthcare delivery. Gear yourself for an enlightening discussion on telehealth, remote monitoring, telemedicine, future and technological advancements, which we'll discuss and create excitement within the scope of healthcare industry. Our panel of experts is poised to share invaluable insights and engage in thought-provoking discussions that promises to leave a lasting impact. Before starting the conversation, we would like to extend gratitude to our community partners. So we have 4 great companies today. It includes Takeda Pharmaceuticals USA, then we have InfoVision, then we have Jefferson Health Plans, and then iDocs Web Telemedicine. Their invaluable contributions has been instrumental in making today's webinar possible. And of course, a heartfelt thanks to all our attendees. Your presence and participation are deeply appreciated. As we embark on this journey together, our primary goal is to equip you with valuable insights and facilitate meaningful connections. Whether you walk away with innovative ideas or forge new connections, your engagement is a testament to our collective success. Without further delay, let's introduce our esteemed speakers who are there for today's sessions. First esteemed speaker is Anthony Segrest, who's Global Head of Digital Patient Innovation, Takeda Oncology, Takeda Pharmaceuticals US. Our second esteemed speaker is Catherine Ketter, AVP Member Experience at Jefferson Health Plans. Our third esteemed speaker is Alexander Jones, who's Vice President of Product Management, iDocs Web Telemedicine. And fourth esteemed speaker and moderator for today's event is Srirama Srinivasan, who is Chief Business Officer, HLM at InfoVision. Before we begin, a quick disclaimer. The views expressed by all our speakers are personal ones and not related to the organizations which they represent for. So let's begin the show. Let me hand over the stage to Srirama to begin this exciting panel discussion. Over to you, Srirama.
Good morning, good evening. Thank you all for joining us today. Telehealth in the modern context, in simple terms, is the delivery of healthcare to patients anywhere in the world from providers through any electronic or electrical means. The first documented case of telehealth goes way back. In 1874, there was a wounded patient in Australia, and he was treated by a doctor successfully through the telegraph, over several days. Since then, we have come a long way, but then there have been steps. 1920s saw the two-way communication using radios for treating faraway patients. Sometimes even as far away as deep in the ocean, there were ships which had patients which could be treated by doctors on land. And 1950s saw the two-way video communication, at least closed-circuit TV, black and white, and then later color TV come into the main fray of telehealth possibilities in the universities and academic institutions of United States. And now we know we have come a long way since all of that, but the pandemic saw an extra fillip to telehealth and its delivery. What happened during the pandemic was, prior to the pandemic, most of telehealth was consumer paid one-off services. And the telehealth enabled, the pandemic enabled telemedicine and remote patient monitoring to come into a mainstream of its own, where it could be integrated with payer and provider systems. And I think that's here for us. It's here to stay. Congress has two laws to extend the benefits of telehealth to making sure that providers are paid at the same level as in-person visits, which is going to be most likely enacted by 2024 end. And meanwhile, till December 31, 2024, all the telehealth laws of the pandemic have been extended to provide the same comfort to patients anywhere in the world. Telehealth has many benefits, as you know. Patient experience is much better, often, depending on the situation. It can be faster. It can be where they are. For doctors and nurses and specialists, it avoids burnout. They can provide services to multiple patients in different facilities, or they can sit at home in the after hours and weekends and provide consultation to patients remote and far away. So it helps the patient, it helps the doctors. From a pharmaceutical industry perspective, remote patient monitoring has helped a lot in clinical trials and in novel therapies being delivered to distant patients and providers monitoring them from far away, anywhere else in the world. And from the payer perspective, telehealth has enabled faster visits, in many cases, avoidance of ER visits, acute visits, and so forth. So there are many benefits to telehealth. I'll pause here. I'll request each of the speakers to introduce themselves before we go into a deep dive on telehealth and remote patient monitoring, together with their perspective on telehealth, especially as it relates to the post-pandemic era. I'm requesting Kat first, Kat Keller from Jefferson Health, to get this started off with her introduction.
Hi, everyone. So it's great to be here today. A little bit about me. I've been in the healthcare space for 25 years. A lot of applicabilities, I think, to Dr. House calls models of programs that are operated all across the nation. And I think that telehealth has become so much more widely used after the pandemic. And there were so many applicabilities that we saw during COVID that allowed us now to think of how we can use telehealth in a post-pandemic world. So very excited to be here today and thank everyone for your participation.
Anthony, may I request your introduction?
Yes, good morning, good afternoon. Anthony Sygrist here. I'm the Global Head of Digital Patient Innovation with Takeda Oncology. I've been working within the healthcare industry probably a little over 10 years now, between pharma as well as hospital systems. One of the things that I always kind of say is that I'm not traditional pharma because my career really started off in the banking industry, where I was doing a lot of consumer innovation at the retail bank, investment banks, loan, those types of things. So being able to take those consumer learnings and apply them to the patient space has been one of the key things that I have really enjoyed about kind of focusing in on putting the patient at the center of everything we do within healthcare. So again, thank you for the invite. Looking forward to the conversation and participation from the audience.
Thank you, Anthony. Importantly, you bring not only the pharmaceutical perspective, but you also spend time actually working with provider organizations. So we look forward to your two hats from the pharma industry as well as from the provider industry. Alex, can you introduce yourself at this time?
Hello, everybody. My name's Alex Jones, and I am the VP of Product for iDocs Web Telemedicine. We are a telemedicine software as well as service provider for long-term care centers as well as LTACs and regional hospitals. I've had a very good opportunity to spend a lot of time in long-term care centers, SNFs, assisted living, et cetera. And I had a unique opportunity to find out what was working and what wasn't as far as telehealth was concerned, and then to tailor a product around it. So I feel very fortunate to be able to do that. I want to thank everybody for having me today, and I hope I can offer a perspective that's at the facility level as well as from a vendor level together.
Thank you, Alex. Looking forward to hearing about your experiences in this journey. I will start my first question with Kat. Kat, you bring a lot of value from different perspectives. But firstly, I wanted to ask you about the democratization of healthcare, which has been possible through telehealth. How, especially the more challenged economic folks who are more, who find it difficult to travel, who find it difficult to take time off from work hours, as well as payers and providers. How has telehealth enabled health equity across patients, providers, and payers? Kat?
So I think from the health equity perspective, telehealth has really been beneficial for us in enhancing healthcare for our vulnerable populations, those individuals that have disabilities or older adults. As Alex shared, many of the populations that we're caring for in assisted living or skilled nursing facilities. And then those adults, whether they have intellectual disabilities and it's difficult for them to leave the home, or they have physical limitations, being able to age in place and home has been a big focus of the Centers for Medicaid and Medicare. So telehealth is particularly useful in those situations. And then in addition, it's being able to receive healthcare services at home with your primary care, with your specialist doctors, and then removing the challenges that we typically might see, whether it's with an individual that may have a disability. Maybe it's an individual that's living in an extremely remote area where transportation might take them an hour to get to the doctor, an hour to get to the pharmacy. So telehealth has really improved accessibility with being able to receive services, with being able to get those services timely, and again, in the comfort of their home where most people are best cared for. And then it again ensures that all of our individuals that have these unique medical needs have equitable care for every.
Very good. Can you hear me? There was some jitter in the audience. In the webinar. This question goes to Anthony. Anthony, at the therapy or indication level, how do you determine what are the right candidates or what criteria should be considered when evaluating capabilities for remote patient monitoring at a therapy or indication level?
That's a great question. Some of the things that we are working on, and I know a lot of other pharmaceutical companies are working on, is around remote patient monitoring. And in the oncology space specifically, as a disease begins to progress from one line to the next line to the next, it becomes very important to look at it at a disease journey versus just a brand or a specific time. So a lot of the things that we're looking at and kind of focusing in on from a pharma point of view is more at that indication level. Again, it depends. There's a lot of interdependencies. If it is a clinical study, if it is an actual clinical trial, if it is in more of a commercial space, whatever that may be. And it does vary from country to country depending upon regulations. But at the same time, specifically within oncology, we're looking at it more at that indication level. Makes sense for a couple of different reasons. The first one is from a patient's point of view, they could be using one pharma company's product, and then as they progress, they may use another. And if each pharma company brings their own type of patient remote monitoring or some type of digital health app, and the patient's constantly switching, we see patients typically falling out because they're confused as to which platform. So again, it makes more sense from a patient's point of view, from a caregiver that's caring for their loved one, to do it more at the indication level and partnering with clinics as they are looking at a particular protocol, therapy protocol across a particular disease state. So that's kind of there's been quite a bit of research that has been published on this lately, and that's something that as pharma continues to evolve and continuing to look at, and to some of the points that Kat made earlier, it really does depend from a health equity point of view, as well as just being able to, for a patient to feel comfortable in their own home, but allowing that physician to better understand what's going on with their patient, when they are remote. So there's a lot of different things that you have to kind of think about. But that's kind of the big three that I would say are important to remote patient monitoring from a pharma lens.
Thank you for that, Anthony. Most of your work has been in oncology, at least recently. From a cancer center's perspective, how do healthcare systems view remote patient monitoring?
We're seeing that there is a greater adoption, and some of it is paired with telehealth. Actually, from if you're looking at more the academic centers where they have nurse navigators, so cancer nurse navigators that are there to help the patient get appointments scheduled, be aware of kind of side effects. Those types of navigators are very important in kind of the bigger picture. And those are typically coming from the academic centers. However, we've seen a lot of community-based oncology clinics as well moving to this model. So that's something that as we continue the market evolves, the thinking about digital health evolves, telehealth evolves, we will see kind of a continuing push towards being able to leverage this type of technology to help patients and also their caregivers, because especially if a patient, an oncology patient or cancer patient is late staged, the caregiver becomes the primary individual that's getting that patient up, getting them their medications, making sure that they're getting to appointments on time. So being able to have this almost feedback loop between the clinic and the patient while they're at home is very important, because they can, the physicians, the HCPs are actually able to better understand what's going on in the moment for their particular patient.
Thank you for that, Anthony. In fact, telemedicine has a very key role to play, especially in oncology, given that patients go through various stages of the journey. And thanks for that again. Switching to Alex. Alex, what do you see is the primary role of telemedicine in long-term care and skilled nursing facilities?
Great question. So it's important to understand how the landscape is changing. And when I say the long-term care skilled nursing, we're talking about post-acute care. So we're talking about after you get your hip replaced, where they send you off for the 30 days for recovery, as well as actual nursing homes together. So what the landscape is kind of shifting towards is we have more what we call premature handoffs from the hospital. So we have people that are sicker, higher acuity patients getting discharged earlier from the hospital into these facilities. And unfortunately, these facilities do not have a doctor that's there 24/7, 365. It's just not possible. So in telehealth, what happens is it bridges the gap when the provider's not there. And it really helps to prevent those RTAs. And when I say RTA, I mean return to acute or return to hospital. Every time a resident of these facilities goes back to the hospital, it is a disaster for all. It costs everybody money. There are cross-infection risks on there. You lose the bed stay, so it's bad for the nursing home itself. So with telemedicine, you can get in there and you can stop these problems before they escalate to a situation that says, hey, this is a 911 situation, they need to go to the ER. It allows those providers to really get eyes on them and essentially stop a problem before it begins.
Very good, Alex. And telemedicine, especially for long-term care facilities, got a boost during the pandemic, right? Given all the dynamics at play. What do you see the
Absolutely.
role post-pandemic? Has anything changed post-pandemic?
The pandemic reshaped everything. Prior to the pandemic, everybody was aware of these benefits, okay? Everybody knew it would really help their readmissions. However, what we saw is that many of these nursing homes were just sitting on the sidelines waiting for others to take action and get into telemedicine before they followed suit. The pandemic kind of pushed everybody into that, because what we had were these facilities that were locking down. They weren't even allowing the doctors to come in. So what way would a doctor be able to come see their patients? Telehealth is perfect. This also allowed us to really incorporate family members into the mix, because we feel that family members play a key role in the recovery for residents of these facilities. And telehealth just bridged it to make it acceptable for everybody. So what we saw is that about 3 times over the facilities, they multiplied overnight. So overnight, 3 times the facilities all of a sudden had telehealth. You had providers, doctors that were opposed to telehealth, all of a sudden were looking for their next solution. So it has completely reshaped the landscape, and I think for a much better way. And thank goodness we've had one-to-one parity in the billing, which has allowed doctors to get into this a little bit more. It's really been a win-win for everybody. It's one of the good, positive things that came out of the pandemic, and there's not many of those that did.
Certainly, Alex. And people in long-term care facilities are very vulnerable generally, right? So the support they get out of telemedicine must have been of enormous help to them. While talking of vulnerable populations, I wanted to go back to Kat. You covered that earlier, Kat, your perspective on vulnerable populations. Can you tell us a little bit about primary care, specialist care, what those kind of different types of care mean to vulnerable populations as it relates to telehealth?
Great question. And, I think what it's done is it's really, of course, enhanced that access to needed specialists. So we'll talk about first the primary care applicabilities and then specialists. So Anthony brings up a great point. When we are having the patient in our office, they're going to present in their best physical state. They're going to wear their best dress, and we may not know what's in their cabinets. We may not know what that home looks like. So with the usefulness of telehealth, we can see that 85-year-old patient. She's in her chair. It's very difficult for her to get up from that chair. We might say to ourselves, let's implement some home health services. Or, I can see your food in front of you, and maybe it's not the food that's going to be best for your diabetes or your high blood pressure, your hypertension. So I think those applicabilities are great for primary care. And then as far as for specialists, it's really, we need to think about the geography. In many of our rural areas, even in our urban areas, there may not be a lot of choice in specialists for things like dermatology, endocrinology, cardiology, even things like neurology. So being able to offer specialist care through telehealth promotes that access. It's increasing that access. So I think both of those, there's applicabilities that allow us really to ensure we're meeting that patient where they are. We're seeing the conditions that they live in. We are able to see that caregiver on camera with them, and then being able to improve that access to anywhere they need that specialist care. They're now able to get it by using telehealth services.
Thank you, Kat. Anthony, I had a thought on real-world data and analysis, which is enabled by RPM. How can that data enable better patient outcomes for the patient, right? I mean, from one perspective, from a clinical trial perspective, you get all the remote data, but what happens to the patient? How do you enable immediate better outcomes for patients?
It's a great question, and it ties back to what Kat was just sharing, as well as Alex. When we think about digital health solutions, basically remote patient monitoring, and kind of the personas that we would want to monitor, or actually the ones that would benefit the most out of a remote health scenario, is really looking at side effect management, those different types of things. It could be a comorbidity that the patient has, as well as their current medication or their current therapy that they're on through their physician. So if we're thinking about, at home, and this was Kat's point, when they come to the clinic, they're usually best dressed. They're going to put on their best persona for that physician. But at the same time, when they're at home, they may not be in the same situation. They may be delaying informing a physician about a particular side effect because they're worried it may alter their current therapy plan that they may have with their provider. So from a remote care point of view, looking at different types of PROs, which are patient-reported outcomes, which is basically real-world data. That real-world data allows a physician to better understand what's going on. And it could be just their nurse navigator who's helping the patient through their journey, and they can see, oh, your blood pressure is starting to tick up, or I see that your nausea, because in oncology, a lot of drugs do drive nausea symptoms sometimes. So let's do this or let's do that. So it allows the actual HCP to better monitor what's going on in the home setting. At the same time, the patients at home, they're more comfortable. They're not having a nurse coming in every 2 hours or 3 hours to take vitals in the middle of the night. But at the same time, the physician, when appropriate, is using remote patient monitoring to better understand what's going on. So they can have, it's to empower the patient and the caregiver of that patient to have a better conversation with their healthcare provider, their oncologist. And at the same time, it's almost two-way. The HCP or the provider has a better understanding of what's going on in the home setting. So it brings the relationship closer. The treatment plan is monitored closer as well. And that's something that as a pharma institution, we're really looking at how can we better provide better tools to be able to work through and kind of help patients have better outcomes on their particular therapies that they are. And this isn't just in oncology, this is also in chronic space. I've worked in immunology as well in the past. So it's that the connection is that feedback loop. That's what the core piece is between the patient at home and what the HCP is viewing and is taking action on when needed in the clinic.
Thank you for that, Anthony. You have RPM solutions at one end, and then you have the health system workflows. Then how challenging is it to integrate the RPM solutions which you have with the diverse health system workflows which are there out there?
It's very difficult. And this isn't just within the oncology space. This is really, it's across pharma and across healthcare systems as well. The way it is set up right now, there's 2 or 3 significant electronic medical record platforms. And there are tools that can integrate fairly easy, but the way those implementations are very unique to each and every hospital system. When I was working for a large hospital system in the Dallas-Fort Worth area in Texas, I think we had 5 different versions of the same EHR, because as the hospital system was purchasing smaller practices or looking at a new specialty and pulling that type of practice in, they were already on a particular version. So it does become very hard and it's labor intense to do integrations with hospital systems. However, what we've been seeing is that a lot of hospital systems, both nonprofit and for-profit, are really moving into more of consolidating and really focusing in on almost a gold standard for their medical records, a single location for that. That is the source of record, rather than having it across 5, 6 different whatever databases. So from either pharma, a biotech, a digital health company, it requires a lot of effort to really understand what's going on with that particular healthcare's EHR system, as well as kind of looking at what will it take to do integration. But integration is really where the value is. So we've seen a lot of basically the academic hospitals doing this level of integration, not only with us, but also with some of the other pharma companies that are in this space as well, looking at digital health, where does it go in the future? So when you do have that true integration, that's really where that feedback cycle comes back, and it's most meaningful when you do have that, because it's actually integrating into a physician's actual clinical workflow, or it's assigned to a particular queue for nurse advocates or maybe even nurse navigators to be reaching out to patients when they're not receiving some remote data, whether it's weight, whatever it may be, or if they're seeing a particular side effect or a symptom that a patient may have, they may want to do an outbound call to better understand. So it puts the proactive piece together when it's highly integrated. But it doesn't mean that the remote patient care is not as effective when it's not integrated. It's still there. It's an extra portal that a physician or a provider may have to log into, and I know that's not popular across physicians because it's adding to their workload. But at the same time, it still allows that treating physician and staff to better understand what's going on. So that's where the value comes in from a hospital system, because they're able to actually focus in on which patient needs my help first. And rather than having to, in the past, it was kind of scanning a list, hey, these. And then at telehealth, it's more about patients making appointments. So there's kind of this whole thought that if we're able as a healthcare system to better understand what's going on in the home setting, then we could be more proactive about that. So it could go across diabetes, it could be rheumatoid arthritis, it could be in oncology. So there's lots of different ways that this can kind of come together.
Thank you for that, Anthony. Of course, the first step is to derive value from the standalone systems, but then the greater value comes from integrating these systems, and the technology providers, whether on the RPM end or EHR front, have to really step up to make the true value come out. I'm going to go back to an earlier topic of vulnerable populations, especially in rural and underserved communities. Kat, could you talk a little bit about how telehealth is impacting rural populations, or what benefits you see it driving in the future?
Yes, I think this is another great question about how we can improve the access to telehealth, especially in these rural situations. And we've talked a lot about the technology, but there's also the patient experience piece of it and the patient education piece of it. So, making materials on telehealth available in a number of different formats, and also making sure that we are doing that. We're calling attention to low English proficiency or low health literacy. So incorporating maybe images or words when we're using online communications, or maybe there's a brochure that a patient gets about telehealth, that they get about how to use the telehealth platform. I think there's also patient education that has to go into using technology. A lot of times in our rural areas, we may take for granted that everyone has internet access. That internet access may be quick and speedy. More often it's not. It's slow and can be a little broken. So I think doing those things, and then also, again, when we're thinking about how to incorporate this and how to get the most patient adoption, is incorporating post-visit surveys after the patient has seen the telehealth practitioner, measuring patient satisfaction and NPS, which is Net Promoter Score. So the most highest factor of NPS is really how likely are you to recommend the service that you received in telehealth to a family or friend, making sure that patients are feeling comfortable with the service they're receiving. So maybe as a telehealth organization, you're doing surveys or patient outreach to a certain population to say, not just here was the survey, but face to face, how did that visit go? What could have made that visit better? Was it in a language that you preferred? Were you getting materials at a literacy level that you understand? Using inclusive patient intake words and jargon. So what is the patient preferred name that we're going to use during that telehealth encounter? What's their pronouns they prefer us to call them? So doing all of that, and I think getting patient preferences before the visit even occurs. So in your intake process, building that patient experience into everything that you're doing is going to help with adoption, whether you're using it in an urban setting, whether you're using it in a rural setting.
Very good, Kat. Thank you so much for that. And, Alex, you've been in the telemedicine delivery program, right? I mean, having a product and delivering it to healthcare facilities. What challenges do you face, when you are trying to onboard a new long-term care facility or acute care facility to a telehealth program. And I would also like you to talk about what mistakes they make and how it can be avoided. We can come to that separately, but let's talk about the challenges first.
Yeah, there are many challenges with starting a successful telehealth program in long-term care. And unfortunately, the biggest obstacle to get around is still the medical director pushback. So unfortunately, there's a preconceived notion about telemedicine that they're going to lose their patients to another doctor, that another doctor is going to be taking care of them, they're not going to be able to bill, et cetera. That's a big concern, and one that has to be overcome. The second is that Anthony kind of touched on with workload and integration is staff timing. I mean, the caregiving staff does not have time to implement a new program in place. They need something that's going to save them time. It's going to be more efficient in what they do. And integration is a part of that. If they have to take fresh vitals every time they send out a telemedicine request, or they have to do a full assessment every time, they're going to do it less and less. So you have to make it so streamlined that it's just so simple, so quick that it happens. And I'm sorry, what was the follow-up question to that?
What kind of mistakes they make when they launch a new program and how you can avoid the mistakes?
Okay, good question. So the number one mistake is that they just turn on a service and think, okay, we have telehealth now, it's going to work itself out. And you have to have buy-in from all parties. I mean, you really do. You have to have buy-in from upper management. You have to have buy-in from your shift nurses, everybody across the board. They have to believe in telemedicine. They have to want to use telemedicine. You can't just turn it on and say, here, figure it out. The other thing is you have to put clear policies and procedures in place for this, saying, okay, we have a change in condition. It's not a 911 situation. As opposed to picking up the phone and calling the doctor, why not try telehealth? That way the doctor can see, or the NP, whatever the provider may be, they can see that resident, they can see the patient and say, hey, they don't look the same as they did yesterday. I could tell they're grabbing their left side, something's hurting, appetite, whatever it may be, but it allows them to see things, and that really enhances the treatment power. So you have to have everybody buy in, everybody believe. You have to make it super easy, and you have to integrate. So integration is a huge key that Anthony touched on earlier. But if you don't integrate into your existing systems, like your EHR, it's not going to work. You have to have a comprehensive platform. It can't just be pieced together from little pieces. Okay, we're going to have it as a piggyback system here, a standalone here. It has to all encompass together.
Very good, Alex. Thanks for that. And that gives me a question for Anthony as well. Should pharma launch standalone therapy-specific RPM solutions as a starting point? And, as you take further steps in the journey, how do you, especially in oncology and remote monitoring, how can you work on integration, partnership, or collaboration with the EHR or EMT providers, standalone to fully integrated systems? Could you tell us a little bit about that, Anthony?
Yes, that's a hard question. But one question that's very important, I would say, if I think through my career over 3 different pharma companies, and trying to look at remote patient monitoring, as well as what we used to call companion apps to help patients with adherence and other things, it is typically not successful to do a standalone type of an app for a brand. You have to better understand what that patient's disease journey is. What are they on? This gets back to some of my original comments when we first kicked off the webinar, is that especially in oncology, patients can progress very fast, and the medical physician is trying to get ahead of progression of disease and try to really provide better outcomes to their patients. So as we look at remote monitoring tools, it has to be in a collaboration. And this goes to exactly what Alex was just saying just a moment ago. It has to be integrated as part of their workflow. It cannot be adding additional. But when we kind of think about what that solution is, once you do have a team, whether let's just say it's a lung cancer team at a particular hospital clinic or a series of clinics, that's interested in doing remote patient monitoring, it becomes a little bit easier because then they can actually start looking at the data. When it's a new idea, whether it be telehealth, whether it be digital health for remote monitoring of patients, there's going to be a lot of skepticism in it because it hasn't really been out there that long. But just like with what we saw with the pandemic with telehealth, we're seeing also a push globally to do more patient remote monitoring. And there's been consortiums across pharma looking at what that might look like going forward for patients and on a global scale and even at a country level scale. So it's a hard question to answer. And I'm sorry, I'm kind of doing kind of a circular on this, but the core piece is that you really need to look at it at a disease state, especially in oncology. And then from there, it is partnering with that healthcare clinic or the oncology clinic to better understand that regardless if they're on our brand or not, we're at least, pharma is helping the patient along that journey with the therapies that can potentially give them better outcomes in the end. So that's where we at Takeda Oncology are really focused in on. Yes, old pharma thinking, it makes sense to do it just brand only. You can brand it, those types of things. But when you're in oncology, you really need to be looking at the patient's overall outcomes, their progression-free survival, their overall survival, the efficacy of the actual therapy that they're on, and helping that, not really helping, but providing tools that facilitate this circular kind of feedback loop when patients are at home. So the physicians, using their own expertise, can actually maybe intervene before a side effect escalates to a certain point, or a certain symptom that maybe new gets reported a little bit faster back into the ACPs as well. So it does require that integration. It does require ownership and buy-in from all the different groups within a healthcare. But we've seen success going in and kind of looking at it from maybe a particular department area, such as lung cancer or breast cancer, uterine cancer, whatever that may be.
Thank you, Anthony. We've gone deeper into the topic of telehealth and remote patient monitoring. But taking a step back, as telehealth becomes more and more a part of integrated healthcare delivery, Kat, what are some of the factors one should keep in mind in choosing a platform? If we want to go back to the basics, a telehealth platform, what are the factors one would need to look at?
Yes, I think first and foremost, you need to ensure that the interface on your telehealth platform is very user-friendly. It should be easy to navigate for both patients using it as well as your providers or your physicians. You also have to, as an organization, consider the compatibility of that platform with all the other operating systems that you're using. So checking whether it can integrate seamlessly with your electronic health record, your EHR, your CRM, your customer relationship manager, as if it won't integrate, if it doesn't have the APIs, you're not going to be able to enhance patient care. And then identifying what patient engagement tools you have built within that platform. Engaging patients really is vital to making sure that it's a great tool for your patients to use, for their families to log on, because in a lot of the cases that we're especially serving in rural populations, we're serving older adults or people with disabilities. It's usually not the patient that's the end user, it's their caregiver, their family member. And then choosing the platform that's offering tools like secure messaging to the provider, reminders to the patient that their visit's upcoming, reminders that they may need to follow up with getting a prescription filled or getting a connection to a home health agency. And then making sure that you have patient education materials that are fostering that active connection. But most importantly is also that you have the resources internally to maintain your telehealth platform if you don't, really choosing the right partner. And I often encourage organizations to really think outside the box, especially we're in Medicare Star season, we're in CAP season. There's a lot of changes coming to those rating systems that we use, is getting that third-party input, stepping outside the box where you're standing to think, is the telehealth platform that I'm using the best one? Is it getting the delivery on return on investment, or do I need to look at a new partner?
Very good, Kat. You talked of engagement and adoption. It's very key, especially in the healthcare industry, where both the patient as well as the providers are often harried. Harried in the sense the patient is in some form of distress, and the providers are constantly close to burnout, the way healthcare is shaping up today. Anthony, the key to better outcomes is better adoption, right? So how can pharma, oncology, payers enable this better adoption of telehealth capabilities?
That's a great question. And one of the core things that come to mind immediately is when you're talking about adoption, you really do need data. So as different digital health platforms, remote monitoring platforms, telehealth platforms, as they can generate data and kind of demonstrate that they can drive efficiency within a clinical workflow, reducing the amount of time it takes to work with a patient, triage a patient, whatever those things may be, then at that point in time, then you have a kind of a benefit to the actual hospital systems themselves. So, we can build nice, shiny, digital, patient-facing apps all day long that can collect PROs, but if we don't have that buy-in from the healthcare system and really showcase where these tools will drive benefit, not only from a payer point of view, but also from a health equity point of view and an outcomes point of view, from a hospital system, then that's when you actually will start to see scale. So there is still some doubt, I would say, that these tools may work the way they are kind of presented. But I think that, as we go over time, we're going to see these digital health platforms, telehealth platforms becoming more and more integrated with just the clinical workflows that patients have, and that relationship a patient has back with their physician and the physician with their patient. So that's kind of where I see this, is really looking at that integration has to really kind of demonstrate the benefit. Sometimes there's someone on our team that always kind of uses the phrase, is the juice worth the squeeze kind of thing. So that is true. We have to really look at what it is that we're trying to actually focus on, and aligning a very complex hospital system network with a particular tool is a task in itself, whether it be telehealth or whether it be remote patient monitoring through digital health. You have to really understand how the hospital system works and how do you work closely with them to drive that benefit to them, versus just throwing it over the fence and trying to sell a very shiny new object that works probably very well with patients, but if it's not integrated, then that's where the breakdown will be. So that's where I see kind of adoption coming in, is this almost partnership collaboration between healthcare, the payers, as well as kind of the digital health, telehealth platforms.
Very good, Anthony. So the full benefits, the potential benefits of RPM can only be realized if there is adoption by patients, providers, pharma, payers, right? The entire ecosystem. Would you like to comment on that, Anthony?
I would. I would say that it does require patients and the different stakeholders, whether they are payers, whatever, hospital systems, treating physicians, oncologists, radiologists, all these different teams that are involved with oncology care. At that point in time, you really have to better understand what is it, kind of this treatment plan that is going on. So I know that through a lot of research that's been published lately in the last 4 to 5 years, it's been focusing in on very specific cancer types, and even chronic cancer, other chronic diseases, not cancer, but other chronic diseases. So once you better understand what that journey is, at that point in time, then you're better understanding what the unmet need is along the patient's journey, along the HCP's journey, and that could be a medical oncologist, it could be a radiologist, whatever. Then once you better understand that in the journey, those unmet needs you're actually solving for. So, the work that Alex and team are doing around telehealth, that is exactly, they're solving an unmet need for patients, also for their caregivers, and better helping that patient interact back with a physician or with a physician, whatever that may be. So I see digital health playing that similar role as it continues to gain momentum over time in the next few, I would say 4 to 5 years as well.
Very good. You talked of unmet needs. Alex, there are the obvious unmet needs which are being fulfilled by telemedicine as we provide them to long-term care and skilled nursing. But on the other side, separate from the unmet needs, are there additional needs which are being met, hidden benefits, not widely publicized, not well known? Are there benefits you could talk about beyond the obvious benefits and the through of telehealth in skilled nursing or long-term care?
Absolutely. I think everybody has that preconceived notion that telehealth in long-term care is the patient gets sick, they call a doctor on the screen and they're going to treat them. But the truth of the matter is there are a plethora of different things that can really help a patient and their family. And that goes beyond just the preventive care that telemedicine gives, but it allows the dietitians, the hospice, the therapists, everybody, the specialists, everybody immediate access to those residents. Whereas before, you may wait 3 months for a 3-minute specialist appointment. You can get those on the fly. You can get them going, almost in real time. So that's a major one. The other part is it incorporates the family members. And family participation in recovery is a major factor, especially when it involves a resident of a long-term care facility actually staying in that facility. Countless times you'll have family members that just want their loved ones sent to the hospital when any given thing goes wrong, where that may not be the safest place for them. There's cross-infection risk, there's transportation risk, there's all kinds of risks with that. So having a family member participating in these sessions and knowing, okay, my loved one is getting the attention that they need, it really helps mitigate some of those unneeded hospitalizations that are part of that family member panic. Okay, so that's a big one. The other part is that I touched on a little bit ago is specialists. Now, we all know specialists, they're booked like crazy. You have to get transportation from the long-term care centers and most of the time in an ambulance. It's very costly. It's very inconvenient for the residents. They have to go out in the cold sometimes. They wait tons of time for these people to show up. Telehealth takes away all of that and it brings the access to the care directly to bedside and it allows you to treat those things in place. So these are all the little hidden benefits outside that RTA prevention that really bring a telehealth platform to the next level and utilize the full value of it.
Great, enlightening answer, Alex. Better experiences for patients, reducing doctor and provider burnout, many other unmet needs, right? Talking of
Absolutely.
unmet needs, food. And talking of unmet needs, Kat, I would like your perspective on what else is being achieved by telehealth from a perspective of unmet needs and other considerations which go into telehealth platforms.
Well, I think there's two considerations here, both the unmet social needs and then how we meet those social needs. And Alex brings up a great point in our long-term care facilities and assisted livings, we're meeting social needs because that resident may not have a lot of people that visit them. They may look forward to seeing their provider, seeing specialists and telehealth visit. Versus at home, we also have to think about how are we still making sure those social needs get met. We now may be saving that patient a long ride on public transportation or, having to have her daughter get off of work and do that. But maybe while that patient was seeing that provider in person, she stopped at the bagel shop or she used that as her social connection. So we need to make sure that we are really thinking about how we meet those social needs because more than transportation, food insecurity, housing insecurity, social isolation is one of the number one drivers of SDOH. So just thinking of that forward thinking when we're figuring out how we can meet the social needs of our individuals.
Very good, Kat. Anthony, I'm going to come back to you on a question of how do you measure the success of remote patient monitoring? What are the indicators of, say, remote patient monitoring in oncology care to determine how successful the program is?
Success is defined, if we're looking at it from a tool point of view, it's really defined around kind of the personas that of the users that may actually be using those tools. So is it the patient? Within the patient, are they newly diagnosed and fairly healthy, or have they been on this journey for a while? And quality of life is becoming more important. So if we're looking at the actual tool, you really have to kind of measure, first of all, patient usage and how are they using it. And we know that not all patients are going to use digital. They're going to prefer kind of a analog, either over the phone or coming in face to face, or even a telehealth. But at the same time, caregivers, those caregivers that are responsible for patients that are late stage, typically are very motivated to make sure that the patient is getting their medication, that they're understanding what's happening with their loved one or the person that's in their care. So really, we want to look at are the tools from a remote monitoring point of view beneficial to the patient themselves and also beneficial to the caregivers, depending upon the scenario and where they are with their actual disease journey itself. There's other outcomes, and these are more study-based, so you can potentially look at quality of life. Quality of life tends to become more and more important as we're looking at value-based contracts with hospital systems or with different payers, whether it's private or governmental type of payers outside the U.S. So we want to make sure that we're able to kind of accurately measure quality of life. And there's a lot of different tools, there's a lot of different measurement tools that are out there that can do that. But at the same time, we want to be able to really say, hey, the patient set a goal to be able to spend 1 hour at the park with their grandson. And they were able to do that because they are, reporting that. So it doesn't always have to be almost like an academic type of questionnaire. It could be, hey, the patient set a goal and they were able to achieve that. So that's kind of where, if we're looking at measuring the success, those are some of the core pieces. From a study design, there are going to be very specific things that you may be looking at, maybe one side effect that you're wanting to mitigate or inform a patient around educational materials, more around kind of how to manage that, live with that. And again, that's across all different types of diseases. That's just not oncology. But that's where we really kind of look at those items as what are those intricate points that we're looking at across that disease journey and that we can potentially measure. There's certain things that you can't measure, and we can get into those later, but those things that you can measure in a digital sense in a remote setting, such as at home, those are the things that you really kind of have to key on. But boiling it down to the patient, it's really around quality of life, and is it being maintained, or is it slightly going down, dipping, whatever that may be.
Very good, Anthony. You have the hospitals on one end and the pharma companies on the other as part of the remote patient monitoring exercise. What types of data can best be used to evaluate the effectiveness, from either point of view, hospital or pharma companies?
Right. From a hospital's point of view, it really is patient utilization. We're partnering with a hospital system in the United States that has a very unique, they're very innovative as a hospital system, and they send patients home with a connected scale, like a weight scale that they can get on, a connected blood pressure cup, a connected thermometer, and also a digital health tool. So the patient, there's things that, like heart rate, blood pressure, those types of things you can't typically do through an app on a phone. But if you have those other connected devices, wearables or nearables, then at that point in time, you're getting a better, well-rounded view of what's going on with that patient. So that type of data, which I call passive data because a lot of it is passive, patients not actually having to go in and input anything, it's just connected and it flows back into the EHR. That type of data is very important from a hospital system to better understand what's going on with the patient. They say, yep, I'm moving around, but their Fitbit, they could also potentially connect to this because it's very interoperable. Or their smartwatch is saying, nope, they're not up and around. They're actually sitting, they're sleeping a lot longer. So it's not to prove patients wrong or right in an at-home setting. It's just to give the treating physicians, the HCPs, a better understanding of what really that home life scenario may be. Getting into health equity, and I know this is in Kat's her space, it really it does open up, and that's one of the things that we've seen with our partnership and collaboration with this particular hospital system is that those that are in a more remote rural setting that may not have easy access to get into a specialist at others, this allows them almost a connected way of being able to see that physician or be able to better interact with a particular physician around their disease journey or their therapeutic plan that's been planned out for them. So it does have health equity, a lot of health equity clout as we look at how do we really do this and roll this out with a particular hospital system and get this into the hands of patients and into the hands of caregivers from a remote monitoring point of view.
Very good, Anthony. Just a quick last question to Alex before we get into audience questions. I hope we have time for some audience questions as well. Alex, if I were to start a new skilled nursing facility, what are the 2 or 3 top things I should keep in mind in the selection of a telehealth program, and how do you see the future of telehealth program affecting me and my skilled nursing facility?
Great. I think Kat raised some really important things to when you assess an actual platform, which you should look for. But there are a few key things, no matter what platform you go with, that you have to really make sure are successful. And number one, you have to get buy-in from all stakeholders. I mentioned everybody from the floor nurses to upper management, but everybody has to buy into it. Number two is you have to make sure what you implement actually saves these people time. And the only way to do that is to incorporate telehealth into your existing workflows. So don't put a whole new program of telehealth together and say, okay, this is what you do, outside of your normal practices. Incorporate it all together. And then finally, the third is set some obtainable goals and celebrate them when you reach those goals. So if the staff doesn't know that they're doing well, they're not going to do well. They're not going to continue on those practices. But if you appraise those and you say, hey, you prevented a hospitalization today. We have John Doe here. His family was really happy about this. He didn't have to go to the hospital. And you commend those nurses. You commend that staff. They want to use telehealth more often, and it empowers them. It enhances their critical thinking, and it really helps all parties involved. So those are the big 3 that I would say in a nutshell.
Very good, Alex. Thank you for that. I see a number of audience questions, but many of these questions we have touched upon in this journey today. There are questions about disparities in healthcare access among individuals with disabilities, those living in remote areas. We talked about it. Then there are questions about limited technological experience of elderly patients and how telehealth can be used for them. Is that something you would like to touch upon, Alex? Elderly patients, limited technology ability, limited technology experience of elderly patients. How do you factor that into a telehealth platform?
Well, it's more than just the patients having, adverse technology effects. It's the staff as well, the caregiving staff. You have to make this so user-friendly and almost fun to use at that point that you get them to adopt it. And you have to have, for the geriatric crowd, you have to have very large screens for it. You have to have the large text. You have to make sure they can hear everything. If it is a person that's hearing impaired, you have to make sure that there is text on the screen that they can chat in that way. But all of those things together really help bring down the barrier of the technology adverse crowds.
Very good. And I see one other question about data sharing and integration. I think we talked about it. One new topic which is being touched upon by an audience question is what kind of compliance needs to be considered for telehealth and telemed? And how do you take care of patient privacy, especially during video monitoring? Alex, maybe you can first talk about it, the others.
Absolutely. I mean, we all have to be HIPAA compliant. That's a big one. But, patient data and privacy is so important. So in our platform, for instance, sessions are recorded. However, we leave that up to the actual facility to figure out, do they want to do that? Now, that has its benefits, it has its pros and cons. If you don't get that patient consent, obviously you can't do that. So that brings us on to consent. That's another huge one. All patients and their family members have to be aware of what's going on and never in a situation where it's in the dark, because that will come back to bite you. So not only you have to be HIPAA compliant, you have to make sure that you have compliance for the patients to get their consent. And then finally, you have to have that family part into it. I am a big fan of never storing the patient data itself. I know some platforms take a different approach to that, but with us at least, we don't store the patient data because we integrate with the EHR to pull it from there. We never store it ourselves, because the more people that are storing data, the more potential leaks you have in that, and the more potential problems you have for it to get out of the market.
Very good. I now seek a concluding thought from each of the speakers on how do you see the future of telemedicine in your respective areas of interest. Maybe we can start with Anthony first.
Yes, I think the way I see the future around telehealth, remote patient monitoring, is that it will become more ingrained within the actual clinical flows, the actual workflow processes within hospitals themselves. I also see that standalone apps that pharma may make around remote patient monitoring or whatever, to the points that Alex just made around data privacy, will start to wane. It will be more partnering with digital health companies. So there's several of them that are out there that are kind of leading the way right now, blazing the new trails. And I think that will be kind of the path of the future around remote monitoring, because that way pharma really doesn't have access unless it's included as part of a particular study, which patients have opted in and consented to, access to de-identified data. So that's really where you have to really keep, almost from a pharma healthcare system, at arm's length, but at the same time knowing that the tools that we're collaborating on with healthcare systems, and even across pharma, are looking at that entire disease journey. So that's kind of the direction I see remote patient monitoring and telehealth moving in the next, I would say, 4 to 5 years at the very latest.
Very good, Anthony. Alex, could you chip in?
Yeah, I think I believe in that too, and I think that we're just getting started. So I think as these integrations come together and you have this become more of a standardized workflow where it's first nature to these people, it's going to really take off. And we saw this happen during the pandemic, and it's continued to trickle on, past that. I think the pandemic, the one good thing that came out of it is it really made people accustomed to this, and is standardized that telehealth is equal in most parts to in-person levels of care at this point. And it broke down those barriers. So I think now those barriers are down. In long-term care, at least, we're going to see this so widely adopted that it'll be first nature to everybody on the floor staff.
Very good. Kat?
And I think from the payer perspective, it's making sure that we are including this as a covered benefit with the different products that we have. We're seeing it, more so used in commercial insurance products, which person doesn't operate present day, but we see it in the offerings to our own members. So I think as payers, we need to think about how do we make telehealth a seamless experience for the people that we're serving? How do we make sure it's part of the covered benefits that we're providing?
Very good. From an overall healthcare perspective, the patient has to be very patient wherever he is in the world, right? It's hard to get appointments. The doctor is not always in. Telehealth makes a sea change possible. Once it's fully integrated with payer and provider systems, the doctor potentially can always be in 24/7. There could be some doctor there to attend to the patient. That could be a very big benefit in the future with a fully integrated system. And hopefully those doctors are not as challenged or burned out as, doctors who spend all night at a hospital, take just 3 or 4 calls and have to be available 24/7 sometimes in ERs and so forth. So there's a lot of potential for telehealth. We are at the early steps. 20 years later, we have to wait and see how this is all evolved. But meanwhile, I think this is an exciting journey for all of us. Any of you feel free to chip in with some concluding thoughts. Otherwise, I pass it back to you, Nathan.
Thank you. I think we already had a great concluding thoughts from all the speakers, and thank you, Sri Rama, for the excellent moderation of today's session. A big thanks goes to all our speakers, actually, Anthony, Catherine, Alexander, for your insightful contributions to this amazing discussion on the healthcare industry and particularly the telehealth. I'm confident that all attendees would have found it very engaging, very enlightening. As we wrap up this conversation, I would like to take a moment to recognize and thank all our community partners, speakers, and attendees for their ongoing support and participation over the past 3 years. Your involvement has played a crucial role in creating an environment which is a great conducive to knowledge sharing and the knowledge enrichment. The insights shared by the panel members were truly exceptional, and we appreciate their collaborative effort and expertise. For those who have missed any part of today's session or want to revisit it, the recording will be available on our company's YouTube page for your convenience. Looking ahead, we are excited about the promising technological advancements that lie ahead in the coming months. At AI CoreSpot, we have a diverse line of events planned across various sectors, which includes telecom, insurance, banking, financial, retail, supply chain, manufacturing, healthcare, and much more. So we encourage all of you to stay connected with us for the ongoing learning opportunities and updates on the latest technological developments. You can find a wealth of knowledge, including detailed event announcements and registration assistance on our website and any of our social media channels. Your support is invaluable to us, so please consider liking and sharing our content with your networks. A special mention to InfoVision, who is our esteemed knowledge and innovation partner, and Digit7, who is our technology partner, for their great support and collaboration. Be sure to explore their websites to dive deep into the world of technological advancements. We thoroughly enjoyed as a company, AI CoreSpot, enjoying hosting this session, and hope you found it as enriching as we did. We look forward to continuing our journey together and bringing you more insightful sessions in the near future. Until then, take care. Thank you once again, all of you, for your participation and support. Have a great day and a nice weekend ahead. Take care. Bye.